All right, welcome to this edition of Woo University Smile 101 with Dr. Derek Cunningham. Thank you so much, Dr. Cunningham, for being here with us tonight. Next slide. I'm your host, Dr. Elise Kramer, currently in Miami. Where are you from, Dr. Cunningham?
I am in Austin, Texas.
Awesome. Next slide. So thank you to Zeiss for exhibiting at this event. Next slide. And this is a 1 hour CE course. So for each hour of CE units, attendees must be online for a minimum of 50 minutes in order to get CE credit. For a COPE certificate, there will be a survey link in the chat. The survey link will also appear when the webinar ends. CE certificates will be, if you can go back, thank you. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers, but there's also going to be a QR code at the end of the event. If you have the OE tracker app on your phone, you'll need the OE tracker app in order to get that CE instantly. If you don't have the OE tracker app, it's not a big deal. You'll still get your CE certificate via email within 4 weeks. You can ask questions using the Zoom on-screen floating panel that you can see circled in red. Next slide. And if you're using the mobile version tonight, you'll see the Q&A at the top. If you're looking for the chat, you can click on those three dots at the bottom, and then you'll find more options. We try to keep the chat for more logistic questions and keep questions for the doctor by clicking on Q&A and asking questions there. If we have time for questions toward the end of the presentation, that's when we'll be going over them. Next slide. So I will introduce our wonderful presenter this evening. Dr. Cunningham research covers a wide spectrum of eye care and neuroscience, including dry eye treatments, glaucoma medications and surgeries, retinal diseases, cataract surgery and LASIK surgery, cosmetic treatments and products, vision enhancement, and sports vision. His innovative research has been presented at major national meetings, including the American Retinal Society, the American Academy of Ophthalmology, the American Academy of Optometry, and the American College of Sports Medicine. His research has been featured in many medical journals and showcased in publications such as Sports Illustrated and Forbes magazine. In addition to having been an associate professor at Texas Tech School of Medicine, Dr. Cunningham also held adjunct professor status at the Inter-American University of Puerto Rico, University of Waterloo, University of Houston, and University of Incarnate Word. Dr. Cunningham is an internationally recognized educator, having provided continuing education lectures to eye doctors throughout the world. He is also a fellow of the American Academy of Optometry. He is also the founding chair of the Integrated Ophthalmic Task Force for the American Society of Cataract and Refractive Surgery. Dr. Cunningham is the director of the Dell Eye Institute for Dry Eye Research at Dell Laser Consultants in Austin, Texas, and is well published in the areas of advanced dry eye treatments. Many of Dr. Cunningham dry eye protocols are used by academic institutions around the country. Thank you so much again, Dr. Cunningham, and I will let you take it from here.
Cool. Thank you very much, Elise. So I am going to jump into these are any of my conflicts of interest that you can see right there. And again, fair and balanced, it's every major refractive surgery company in the United States. And I do have the privilege of working and helping with them all out. So what are we going to get to today? We're going to get to something called Smile. Now, this is very interesting. This is not brand new, but it's the newest. And the interesting thing about Smile when it comes to refractive surgery is there's still a lot of misconception about it. And I find that now it's equally probably as misunderstood by doctors as it is also by patients. And so let's get into a little bit of the specifics of it. Many of you are going to be very familiar with the concept of it. Some of you will have kind of no idea what it is. But what I'll do is I'll go through and kind of explain how it applies to optometrists, what it's going to mean for you and your patient base, and more specifically, how can you counsel patients on it and really what the difference is. So where I'm going to start is called this timeline of vision correction. Now, the initial type of FDA correction, now this is unique to the United States, at least it's from Canada. Things were a little bit different there, and they had their own timeline for stuff like that. But PRK was initially approved officially approved here in the United States in 1995. And that's kind of, I came to bring the pain type aspect of vision correction. It's gotten much better, and I'll speak to that when we get into the uniqueness of PRK. PRK also now is typically referred to as advanced surface ablation. It's the same thing. If you step ahead a couple years, you'll get into basically LASIK. You'll notice that I did not include refractive surgeries that were not easily laser based. And the reason for that is I'm not going to talk about RK, I'm not going to talk about ALK and all these kind of crazy things that were done before that because they weren't done mass or on really across the masses as RK was, unfortunately, for a couple of years. But it really doesn't apply because that was a linear type incision into the cornea, and we're talking about laser procedures here. In 2001, femtosecond assisted laser surgery was approved. Now, it had a slow adaptation, and the femtosecond idea was that you were using a completely different laser than the ablative laser that was first approved for LASIK. And remember, in almost all cases of initial LASIK, we were using a microkeratome. So this was a functional kind of deli-like meat slicer that would, take off a cap of the cornea into a random depth into the cornea. We really didn't know if we were going 100 microns deep or 250 microns deep, and we are hoping we weren't creating a button when we were doing it. But those are all historical issues that we had with LASIK that really are gone with the advent of femtosecond surgery, and I'll get to that in a little bit. If you step ahead 15 years, now this is a massive leap when it comes to technology and innovation, especially in a field that was so tech laden and laser laden like this. We didn't get the next major innovation until 2016. And Smile gained FDA approval here in the United States, but was really slow to catch on. So most people, although they may have heard of it, if you were in a surgical center, you probably had no idea really what it was because very few surgical centers were performing it. March 1st, 2007, the first smile cases were formed here in the United States. And again, using kind of a rudimentary functional unit, it was very, very good for the time. But there's been massive increases in technology, efficacy, speed, outcomes. You'll see it and all things like that. 2018, FDA approved Smile to treat astigmatism. Now, initially, the approval was only for spherical corrections. A year later, they had an approval for astigmatism. And then the biggest jump that we've seen, and what I'm going to center around today, is this approval that happened January 11th in 2024. This is the VisionMax 800. Now, this is what's called contemporary, the latest smile that's available. And this took a massive jump. Now, again, I know I'm still kind of nebulous on what smile is, and I'll get to that. But first, I want to get to the idea of why smile came about and really kind of what we're doing with it. Now, before we get to any refractive surgery stuff, I want you to keep a couple things in mind. There are relative contraindications for any type of laser refractive surgery, and there's absolute contraindications. But keep in mind, something as simple as dry eye syndrome, that is a relative contraindication for any type of refractive surgery. But think about a center like mine. How many people do you think walk into my center and say, I love wearing contacts. Can I have LASIK or Smile? That doesn't happen. Everyone that comes into our centers for any type of laser vision correction really is having intolerance issues, typically with glasses and contacts. They just can't stand them anymore. And in contacts, it's 99.9% of the time dry eye related. And this is kind of what fuels a lot of the refractive surgery these days. And I'm going to go back a slide here because I think there's another thing I want to talk about that's a misconception. One of the things that's really important in the surgical space for both optometry and ophthalmology is this idea of what's been happening to the LASIK over the last 10 years. COVID saw a resurgence of LASIK and Smile cases because I think people had money and they had nothing to do. But over the last 10 to 12 years, we've seen a massive decline in the amount of people that are doing any type of corneal refractive surgery or LASIK surgery. And that's left a lot of us scratching our heads. The economists look at it, a lot of these planners, financial planners, a lot of these people that look at trends within society look at this and they don't quite understand why the numbers have dropped so significantly. On top of that, there was this idea, well, maybe we corrected all the myopes. But believe it or not, there is enough uncorrected myopes in the United States that if you had every surgeon working 24 hours a day around the clock, we still could not do laser vision correction on all of them in our lifetime. So it's not that we've used up the patient base. One thing that we think may contribute significantly to the really the downfall of LASIK as far as a major surgery that's done at a high volume across the country is this idea of complacency. LASIK moved into a commodity market roughly probably 15 years ago when you had these massive discount chains really promoting LASIK and saying, listen, we're just going to bring in any cutter. He's going to cut you. It's the lowest price that rules. Consumers consumers now look at LASIK as something that's done in strip malls by these places that are bait and switch, like used car salesmen. You can come in and have everything done for $99, and then you get in there and they're like, well, it's actually $2,000 because you have more than a quarter of a diopter of refractive error. And so this whole idea of people feel like they've been not only kind of bamboozled by all these LASIK commercials, that it became a commodity and it didn't matter who was doing it. And probably the biggest thing was some complications were happening. And because these surgeons were just doing surgery at these mass kind of production places and then leaving, that wasn't even their practice. There was no one there to take care of them. And so I really feel like that plays into this idea of why LASIK has tapered off significantly in the last several years, last decade, to be honest with you. And we never needed the resurgence of a new technology or a new treatment device or a new way of doing corneal surgical correction as much as we have with Smile coming to the market, especially the latest version of Smile, and I'll share that in a little bit. So let's talk about contraindications. Obviously, if someone doesn't have a proper functioning anatomy within their corneal structure, you don't want to do any refractive surgery. You're just going to put it at risk. And that's Fuchs is a big one for us. In some cases, Fuchs is a relative contraindication, but again, as in generality, you're not going to do it on Fuchs. Clearly, if people have ectasia or any type of degenerative corneal disease, you're not going to do corneal refractive surgery. Now, you'll see this is from the Academy of Ophthalmology, the American Academy of Ophthalmology. Some of these are actually relative contraindications, and some of them you actually perform laser vision correction to fix them. For instance, epithelial basement membrane dystrophy. You certainly don't want to do LASIK on that because you don't want to preserve that into the flap. But man, PRK or PTK is pretty awesome at getting rid of epithelial basement membrane dystrophy and sometimes is a cure for it. So that's something that's important. Keep in mind, keratoconus, marginal degeneration, all the ectasias, they're all pretty much the same. They all just need to be cross-linked as soon as you can. And then some of them you can actually go back and do surface ablation on or PRK. Peripheral retinal scars was something that really was a callback to when we did manual microkeratomes. Now that's when you put a flat blade on the cornea and you had to provide a ton of suction to flatten out the cornea. And that ton of suction drove the IOP up massively, and you could have gotten retinal detachments if you had tears in the periphery. That is incredibly unlikely with today's technology and the way that these curved interfaces are working, that you'll see pressure doesn't go up really much at all. And obviously in PRK or surface ablation, there is no pressure on the eye at all because there is no applanation in that case. And we'll talk about that a little bit. Systemic autoimmune disease is something that's a historic contraindication. I can tell you that there's plenty of studies that have been done, especially some in South America, Brazil, many years ago, that looked at retrospective studies where all these people with specific autoimmune diseases, not not all of them, but certainly the more common ones, connective tissue disorders, rheumatological disease, they tended to do relatively fine as long as their systemic disease was controlled. But it does carry increased risk, and that's something that you have to talk about your patients with. And then you have pregnancy. Don't do anything ever on a pregnant woman unless you absolutely have to. And then lactation is the same thing, believe it or not. Lactation, not only do you worry actually more about systemic absorption of drugs when a woman is lactating, it's the same thing with refractive surgery. And don't assume because they're 6 month postpartum that they're okay to have refractive surgery. I had a patient the other day, she was 2.5 years postpartum, and I asked her if she was still lactating, and she said, "Oh yeah, I'm still breastfeeding." So again, you got to make sure that the breastfeeding is done and they're actually done lactating. Severe dry eyes. Again, this is an interesting one because contact lenses cause dry eye. That drives people into having refractive surgery, corneal refractive surgery. There's relative numbers here. Your surgeon really and your optometrist probably working at the center, or you working with your surgeon, have to decide what's acceptable and what's not. In the short term, corneal refractive surgery tends to make dry eye worse for about 6 months. In the long term, contact lenses are probably worse for dry eye because of the prosthetic irritant effect that they have. Significant blepharitis, again, relative contraindication. And the biggest one is any active inflammation. And I'm talking, any type of inflammation. If someone has herpetic disease, if someone has uveitis, if someone has, any type of vitritis, all that kind of stuff. Don't touch them until it's calm, and it's been calm for a while. But they're not absolute contraindications. They're relative contraindications. So this is the three things that are available. And these are very simple ways to look at what we can do. PRK was the first one that came to market. That involved an ablative laser. All right, that's a photoablative laser. And what it does is it basically burns tissue. So it resurfaces to however you want it to look. So it's going to resurface the cornea using heat, basically burning it off. And that's why you can smell it. And sometimes it creates smoke into kind of what you want. And the only downside to this, as far as PRK goes, is it took a while to heal because you got to wait for the epithelium to grow back from the periphery. It's very reliable though. The military historically loves PRK because they don't care about discomfort. You can have discomfort for a while. What they care about is results and that the soldier can't screw it up. And the great thing about PRK is it's almost impossible to screw up from a patient standpoint. So that's why a lot of these major military institutions still to this day love PRK. Now keep in mind, until Smile came out, also there's certain types of occupations where we would only do PRK. For instance, if someone is special forces in the military, we only do PRK. Navy SEALs, stuff like that. If someone is a professional basketball player, so for my sports vision side, that is the leading cause of eye injuries in the United States from all sports. So professional basketball players, mixed martial artists, anyone with a combative role that gets punched in the face, they were all only getting PRK because it doesn't carry a significant risk should you have eye trauma down the road. All right. Now that's PRK versus LASIK. I'm going to talk about how Smile has changed the game just a little bit. And then LASIK came out and it started using basically a different laser. Now, it started using a femtosecond laser, not an excimer laser. The excimer laser is the one that goes and photoablates. The the basically femtosecond laser is kind of a cutting laser. I'm going to explain that in a little bit. But what that was able to do, and the whole reason why we developed LASIK, is you could preserve the anterior stroma and preserve all that epithelium that you had to throw away before. And when you moved it out of the way, because the cornea itself is one of the fastest healing tissues in the human body, and it almost starts to heal instantaneously with the collagen itself, you could then just get that tissue, save it, move it out of the way with a flap hinge, then you would do your ablative surgery on the cornea, and then you could put the flap back down. And that was really the genius behind LASIK. And that's what allowed people to wake up the next morning. They heard angels singing, there was theme music wherever they went. That was LASIK. That's why 99% of the population got LASIK. That's why everyone loved it because they were on Facebook and Instagram the next day saying how amazing their vision was, how awesome everything was. And that's kind of really why that took the lion's share of the business, because obviously no one wants to wait to heal. And LASIK carries its own risks, but we'll talk about that. And then we had Smile. Now, Smile flipped it again. You went from using an ablative laser in PRK to using an ablative laser and a femtosecond laser in LASIK. And now you're just using the femtosecond laser and you're not using the ablative laser. And this is where you're just cutting out the section that was going to get burnt away anyway, but you're doing it all through the clear cornea and making a lenticule, and then through a small incision, removing it and letting it heal. And we'll talk about why that was a major innovation. So let's get back to the femtosecond. What is the femtosecond and why is it different than these ablative lasers? Well, the femtosecond laser is completely different than an ablative laser. They're really fundamentally different type lasers. The femtosecond laser is an ultra short infrared burst, and what it does is cavitate a bubble. So it causes plasma to be generated in the tissues, and it can focus on anything that it can see. So as long as it's transparent tissue, you can go to whatever depth you want. And the other really important thing is we have actually down to the level of microns. So when you're cavitating these bubbles, you can do it on a plane down to the order of 1 micron. And so this is what's really remarkable about it. And when you put them all in a line, it creates a perfect incision. So think about your femtosecond laser is like an incisional laser, and it doesn't create heat. All right. So you don't have to worry about basically being concerned about contralateral tissue damage or anything like that. And that's what's really remarkable about when you do these femtosecond cuts. They are very, very quick, very, very quick. They are insanely accurate. And you do have to stabilize the tissue, though. That's one thing that's different. With ablative lasers, you have some fudge room. You have some air for micro movement. With femtoseconds and lasers, you have to stabilize the tissue, and this is typically done by docking the eye. Now, if you've ever been to the mall and you've seen these little glass cubes that you can get made with your friend's face or your family member's face or your dog's face in them, that's the exact same laser. So that femtosecond laser will also be used to create 3D images in glass. And this is how a lot of these award shops are doing these cool little things. So the same thing that's done there is actually the same thing that we're doing on people's eyes. And as long as you can see through the tissue, you can use the femtosecond laser to go ahead and disrupt local area, and that creates this refractive index change, and you get these kind of really three cool 3D blocks that you'll see that we can put throughout a lot of this stuff. All right, so let's get back to the concept of why you're doing these different surgeries, what can go wrong, and I'm going to talk about what can go wrong from the surgical standpoint of the surgeon themselves, and then I'm going to talk about what you as a referring or a co-managing doctor, or even just someone who's seeing a problem afterwards is going to have to deal with. PRK again was loved by a lot of, I would say, historic institutions because, like I said, the patient can't screw it up. But during the surgery, there's some things that go wrong. You have to use a small weld that you put on the cornea, and then you have to soak it in a little bit of alcohol. Sometimes the surgeon or the patient will move, or the surgeon can get lax with the using the or holding the well in the cornea, and some of the alcohol can spill onto the cornea. And then you have to rinse the eye like crazy, and then you can just start your PRK procedure again. But at that point, you're just going to wipe it off with a sponge, or you're going to use a spatula to wipe off the epithelium. And then you're going to go ahead and just ablate with your ablative type laser. Pretty common stuff. You throw a BCL on, you give typically a non-steroidal anti-inflammatory and an antibiotic to use for 4 days, 4 or 5 days. Take the contact lens off, and the cornea is almost totally healed by that point. Keep in mind, though, when you do PRK, although the cornea is healed in 5 days when that bandaged contact lens comes off, their vision can take several months to get back to like 2020. And the way that it goes with PRK is when you get PRK, you have it, you're functional in about a week, really functional in about a week. And that's great, but your vision's great, or your vision's good, it's not great. It's probably several months, 2 to 3 months before you look up the moon and say, I've never seen it that clear before. That's how slow PRK heals. And for that reason, when I do fighter pilots, we ground them for 3 months. Even if they said they can go back, they can do, they can do sim work, but they're not going back in a plane for 3 months. And we don't even check their vision for that long. And on top of that, the pain that was that used to be associated with PRK, it's really not that significant anymore. I would say 20% of all people that have PRK have discomfort afterwards. 80% have none, no discomfort. And if they get discomfort, they get the night of the procedure and then 2 days later. Don't know why, but that's just how it goes. LASIK, now that was, that's the cream, that's cash rules everything around us kind of stuff. And LASIK came out, and that was the practice builder. And that was the big rush for these surgeons to start doing high volume procedures because you could turn over people so fast. You could return them to daily activities the next day, and everything was great. But there are problems that can happen with LASIK. The first one is when you're creating the flap. You're using a femtosecond technology, but again, the eye has to be docked and has to be very stable. Sometimes during the docking process, it could lose suction or eye can come loose. And at that point, if it's significant, you have to convert that patient to PRK. But you can instantly convert it to PRK, regardless at what level your flap creation stopped at. Then once you create the flap, you have to lift it. Now that's usually pretty easy, but sometimes you can tear the flap a little bit when you're lifting it. It's rare, but that can happen, and that can lead to some problems as well. The corneal sculpting is done with the ablative laser, and I'll show you that in a little bit. And then the flap is repositioned, and repositioning can have some issues. Right? And then that's where you can also get into some surgical issues of not washing out the flap interface enough, getting some corneal ingrowth issues, some wrinkles, some stuff like that. And we'll go over that in a little bit. Well, if we go over to Smile, now you're using that femtosecond laser exclusively, and you are performing the majority of the surgery inside the cornea, not on the surface at all. And you're going to create basically a lenticule that is going to mimic the amount of tissue that would have been ablated off anyways. You're going to completely separate it from the surrounding tissue and allow the surgeon to go in through a tiny incision and just pull that tissue out. Now, there are some issues here. Again, if you break suction during the creation, then you may have to revert to LASIK or even PRK, or ever so slightly, ever It's really rare, but the surgeon can sometimes have some issues pulling the lenticule out, and then it has to be washed out, usually just with saline. So, what do we have to know about as doctors for PRK? And what's really our biggest concern? And I'm not going to cover everything. I'm just going to cover the more common ones. The first one is a slow healing patient. It tends to be if patients aren't healed by 5 days, they can be a little bit of a pain in the butt. And sometimes they can go weeks without being able to close their central corneal area. And the reason why this happens is twofold. Number one, it's the area that's furthest away from the blood flow of your ciliary area, ciliary circulation. So it's furthest away from your body's immune system. The second thing is contact lenses can often bear on the center of the cornea and not allow the epithelium to fully heal over here. So sometimes these patients, this guy's like weeks out. You can't just sit on this with a contact lens forever waiting for this to close. Sometimes you have to go and you have to remove the leading edge of the epithelium to allow it to then regrow back properly. And so, slow healing patients you have to go and debride after several weeks. That's a pain in the butt. Usually this does not cause a problem, but if they sit like this long enough, like weeks and weeks and weeks, you can get stromal scarring happening in that central button, and you don't want that. The other one that was rare since we started using mitomycin during the soak period. So we remove the epithelium, and almost anyone over like a -3, we soak with mitomycin, an antimetabolite, just to stop the risk of haze formation over time. Sun exposure will also increase the risk of patients getting haze. Now, again, this is a very rare complication, but it is something you have to be aware of. So when you see haze over time, usually it's not visually significant. Ever so once in a while, it can be visually significant. If it is significant, you may consider burning through it again with another PRK. And I don't know, you're doing like 5 minutes of mitomycin if you have to. You don't want to kill the tissue, but you have to make sure their immune system won't come back and haze it up again. If someone hazes initially, they're really likely to haze again. So remember that as well. LASIK. So what are the issues with LASIK? And I'm just going to show you a quick video to discuss, and I'll kind of go through some of our issues with LASIK. Initially, with LASIK, you put a speculum in, you have to dock the eye. So you got to use some type of apnea device to dock the eye. You're going to create your flap. Now, at this point, like I said, suction loss will cause you to revert to probably PRK if you don't have a full flap creation. Then you're going to lift the flap out of place. The ablative laser is using a flying spot pattern because the ablative laser creates heat. So it has to constantly vary where it's going to ablate because you don't want contralateral damage and you don't want heat buildup. So when you're watching LASIK being done with an ablative laser like this, an excimer laser, you're going to see it kind of dance all over the eye constantly and go back. And that's just generally not to allow heat to build up. And again, you'll also have some type of typically tracking device here because you have to ensure that the eye isn't moving too much. And so some of these systems will kind of move up and down and torsionally as well. And then putting the flap back down, there can be some problems. Usually the biggest issue here is if there's meibomian gland secretions in the flap interface. If the flap interface wasn't washed out well enough, there's some epithelial cells that will cause epithelial ingrowth, or if the flap edge isn't sealed well enough. Now, the biggest issue with LASIK that we all used to super worry about was Sands of the Sahara, or DLK. This is relatively rare. If you see this, you got to hammer it with a steroid like every hour, like super aggressively. You should call your surgeon right away. But if hit early, it tends to resolve pretty darn quickly, as long as you can get the steroids on it right away. And this will kind of look like grains of sand in the interface. And I actually worked in El Paso, and I got to meet the guy that coined the term Sands of the Sahara, Greg Maddox, back in the day, which is pretty cool. And then you have this. This is the nightmare that we all worry about with LASIK. And this is what keeps us all up at night. And this is what, if you're taking call at a surgery center or if you have a patient that had LASIK, this is the one thing you worry about. And when I have patients that have LASIK, the one thing I tell them before they leave the door is the only thing you can do to screw it up is rub your eyes in the first typically 3 to 4 days. And so because of that, you have to have the shield on at night because if you don't put the shield on at night, you might accidentally rub your eyes. Not only that, about 15 years ago, I had a woman a young student at University of Texas, on the doc for University of Texas. She wasn't an athlete, thank goodness, but She came in, she had LASIK, she went out partying the next weekend. She forgot that she didn't wear contacts anymore. And when she was drunk, when she was at home, she was trying to take her contacts out a couple days after having LASIK. And she ended up pulling her flaps off, trying to take her contacts off. So, again, not great stuff. So, a dislodged, wrinkled flap is the biggest, most common issue that we'll see with LASIK. And it's not fun. Now, you can have debris in the interface. If you see significant debris in the interface, it's got to get washed out. It's got to be lifted, washed out by the surgeon. If you see just a little bit of debris, especially periphery, meibomian gland secretions, stuff like that, that can tend to be encapsulated, sterile. It's not a big deal. If you see microstriae, which typically happen the day after or the day of LASIK on high prescriptions, these are tiny little cracks in the epithelium. That's because the steep flap was put back down on a flattened stromal bed. Those are relatively insignificant. Those go away. If you see in this case, not only do you see these macro striae, these big staining striae across the center of the cornea, as well as almost always you'll see an associated gutter to one side, this has to be lifted and set back down. You don't have to do it the same day. It's fine if you do it a day or two later. This isn't an emergency. It's just the earlier you fix it, the better the patient is. And these typically can be fixed almost all the time, and they end up seeing pretty darn well. Now, why smile? Well, the big thing with smile is it mitigates a lot of those concerns we just talked about. Smile itself now is pretty slick, and I'm also going to spend a little time talking about how it mitigates those risks. But this is a pretty slick procedure where you're going to use this fancy machine, and I have this machine, and it's pretty great. This is the 800, their newest version of it. And you have these really kind of cool arms that kind of come down over the patient's face. It's a very compact system. The whole laser itself moves, which is cool. The bed doesn't. And then you have this observing microscope. Now I use the optics on this thing this is Zeiss optics. So the optics on this thing are so incredible. I do a lot of other procedures, corneal procedures using this setup. But it's a very pretty machine. It's really cool. It's really kind of futuristic, and it's not like the traditional LASIK stuff that we used to use. Very fast. And probably the biggest things here are, people always wonder, well, okay, if you're doing everything with one laser, how are you getting the accuracy that you need? And the biggest thing is it has software that self-centers over the visual axis. Now remember, you have a pupil axis, you have a visual axis, and even during constriction of the pupil, you have a centroid shift typically. And so this will mark and be able to pre-mark and then target the visual axis. And when you do that, you can the machine will allow the surgeon to come right down on the visual axis and mark that for them. So that's a really cool concept that it has here, because again, once you applanate, that's where you're treating. And the other cool thing is it has a cyclotorsion adjustment. One of the things that a lot of people don't realize is when you're sitting up in a chair looking at someone, you're basically your cyclotorsion of your eye is different than when you go supine and you lay back down. So when you lay down, your eye actually rotates. It typically rotates in. And so we have to be able to adjust for that, because when you're laying on your back and especially if you have a lot of stigmatism, your eye rotates and you sit back up and it rotates the other way. You have to want to treat someone based on what their eye is like when they're standing upright. That's usually when people care about their vision the most, is when they're upright, not necessarily when they're laying on their back. So there is this adjustment that's available for, the technician and the surgeon to go ahead and mark this ahead of time. And we'll do this obviously on people who have a fair bit of astigmatism, just to cover our basis there. And then if you want to see how it's done, the thing is super slick and super quick. It's a curved interface, so I'm not worried about raising IOP. The eye does not go black like in LASIK. You don't lose all your vision here. You create what's called the lenticule cut, and then you create a cap cut over top, and then you do your microincision on the side there. And I'm going to show you the kind of a real world example of this. But again, this is all done in the cornea. It's not done on top of the cornea at all. And then the surgeon gets to go in and he gets to remove the lenticule. Now, it's not quite that easy in that the surgeon has to go in and dissect the surfaces. They are kind of cut from each other, but they're still a little bit sticky. So the surgeon does have to go in there and finagle the anterior and posterior lenticular surface away. But when it comes to the surgery itself, you saw how quick it was. The laser procedure itself is on the order of about 10 seconds. And that's super important because even when you're just creating a flap with LASIK, the faster the laser goes, the better the incisions, the less movement, and the less risk of complications. So that's a big deal for us. On top of that, the process is done with very low suction because of the curved interface, so it's very comfortable, and the patients don't go black like with LASIK. Their vision doesn't go away, and that's also very reassuring for the patient. And then the manual dissection is, like I said, it's with surgeons who are skilled at this, it's very, very quick. And these are the cuts. Now, if you think about this for a second, obviously you have to start at the very bottom and work your way to the top because you don't want to try to focus through air bubbles. So you do the lenticular cut, which is the back surface first. Then you're going to do kind of your side incisions of your lenticular cut. Then you're going to do your cap incision. And then at the very end, you'll do your cap opening incision. And that's what everything's going to come through. And so when I show you this, it's going to look interesting, but ideally, the idea here is the amount of disruption is far less than you get with other procedures that are being done. So, super comfortable experience. Like I said, everything we talked about. And there's also, if you worked around a LASIK center, you'll know that roughly kind of anywhere from 5 to 10% of patients can have subconch hemes from the suction ring that goes on the eye. I have never seen that with a smile patient. So let me show you how it goes in real life. And I'm also going to tell you what's being done when it's being done in the time frame when it's being done. So here we go. We're going to start in 1 second. You're going to create the lenticular cut. Then you do a quick side cut. Now in about 2 to 3 seconds, you'll have your cap cut. And then you do your side cut and you're done. That's it. That was it. That was the entire laser procedure. And that's insanely, insanely fast. And so it's faster than PRK. It's faster than LASIK, by far. And then, yes, like there is a little bit of manual dissection by the surgeon. And so the myopic ranges, you can go from -1 to about -10. Now, keep in mind, it's not approved for hyperopic corrections here in the US, and you can imagine why. If you're doing a hyperopic correction, you have to be thicker in the periphery and thin in the middle, and there's a risk that you could tear the lenticule. They're working on that, but for right now in the US, it's myopia from 1 to 3 diopters. It's astigmatism from obviously 3/4 of a diopter to 3 diopters, age 22 and above, simply because that's what the study was just allowed. And then obviously you want a minimum stability, you want a stable prescription. Now, as far as depths, we'll talk about that in a little bit. This still kind of holds true to conventional ideas. If someone has a massive, massive pupil, they may have aberration issues here. You want to make sure they have enough corneal thickness. The corneal cap itself, meaning that the area that you're not touching, that you're leaving intact, natural cornea is about 120 microns deep. So everything you're going to cut is under that 120 microns of preserved corneal surface. Take that into account. Pachymetry should be available, absolutely. You want to look at the limit diameter because there are different sizes of apponation pods that we can use. Obviously, make sure they have stable K readings. Topography, tomography is great. You want to do manifest and cyclorefractions. Now, you don't necessarily need to do a cyclorefraction unless you're concerned about, unstable refractions. You obviously want to make sure the inside of the eye is healthy and good. This holds true for all refractive surgery. And then you want to do obviously your dry eye testing, but I'm going to explain why dry eye testing is not nearly as important with this procedure. Now, here's your contraindications. We talked about these already. There's not a whole lot different here, but some surgeons feel okay going down to a 250 micron residual bed simply because you have what's called a cap thickness. We'll talk about that. And then you have abnormal corneal topographies. That's not good. Ophthalmic stuff. Uncontrolled disease is not great. Diabetes, I'm not too worried about. Unless it's really uncontrolled diabetes. It's the same thing with LASIK. I don't care about diabetes unless it's uncontrolled diabetes. PRK, I care about diabetes because they're slow healers. Remember, that's a hallmark of it. So I'd much rather do LASIK than PRK. I'd much rather do SMILE than the other two on a diabetic. And then uncontrolled glaucoma, you're not going to do anything on someone with uncontrolled glaucoma. You need to fix that first. So, what is it great for? What does SMILE really change the game for? The active lifestyle. That's what's been the big change is the active lifestyle patient. Let me just check the chat quickly. I want to make sure we don't have. All right. Now, the active lifestyle patient. So if you talk about what's been big, it's been this idea of returning to what you like to do. So when we have these young people come in anywhere from 20 to 35 that weren't doing refractive surgery anymore, now that they've heard about Smile, they see it in a totally different manner. It is a totally different type of procedure. It gets away from a lot of the concerns that they had with LASIK or surface ablation. And if you have a patient like this that says, listen, I'm only in town for a little bit. I have a job that takes me away quite a bit. I need to be functional as quick as possible. They have their relatively -3 prescription, by the way, which -3 is the most corrected prescription because it's the most common myopic prescription seeking refractive surgery. Uh, you basically have these patients that are ready to roll the next day with very little restrictions, and we'll talk about those in a little bit. So recovery, what does it come down to? Well, because we're only doing a micro incision, because think about this, LASIK goes almost 270 degrees around the cornea to create a flap. Smile is pretty much the opposite of that. And so when I have such a small corneal incision, I don't have to worry about flap dislocation. I don't have to worry about all those major things that even with the LASIK patient caused us to have pause as far as their daily activities. These people can return to work the next day, no problem. They can shower the next day, no problem. They can drive the next day, no problem. And in my case, I don't restrict gyms right away. They can go back the next day, and that includes weight training or anything like that. I do like them to give a break on a couple things. Swimming, I still don't want any type of hot tubs, pools, lakes, or rivers, all right, for at least the weekend for the reason of that small incision needs to heal. And just in case it was a slow healer or you have an epithelial break. And then the second thing is eye makeup simply because of the amount of rubbing on the eye. I don't think it's a problem, but I do like them to wait one weekend for that as well. Apart from that, it's kind of good to go. And as a matter of fact, the shield is only truly probably necessary for the first couple nights, if at all. But we'll still kind of tell them to wear it through the first weekend. And we're doing surgeries on Thursday, so we have them wear it through the first weekend. By Monday, they're all resuming normal activities, full go, like nothing. LASIK, you're talking about all this stuff pushed out to a week, for a lot of the significant stuff. So we don't want them to do anything really strenuous, aggressive contact sports or anything like that for a week. So this allows people to resume activities much quicker, much quicker. So in my other life, in my sports vision life, where I do a lot of elite athletes, I got the University of Texas athletes, I got a lot of collegiate athletes, I got military people. And the military does love Smile. The military loves Smile a lot. We're doing it on a lot of active duty guys. It's kind of one of these things that it just relies on these people to reliably return to life almost instantaneously without the things that we used to worry about uh, historically. So there's been 10 million people now treated worldwide, and endless publications and all this kind of stuff. And this is crazy because we still see this kind of as a fringe new technology. And, it's really not. But if you look at the amount of success it's had globally, it's really interesting. It's here in the US, it really hasn't caught on yet. So I want to go through a couple of studies because people ask me this all the time. When it goes through lenticular extraction, if you want to call it SMILE, which stands for small, yeah. Anyways, you've seen it. When you go through lenticular extraction, small incision lenticular extraction, basically you'll see that initially when the studies were done, this was using older platforms. The accuracy was pretty good, on par with other refractive surgery. But with time, as things got refined, the refractive surgery got better and better. So if you look at the latest study, these are all domestic studies. If you look at the latest study, the Reinstein study that was done in 2022, you have 95% of eyes getting a best corrected, uncorrected visual acuity of 20/20 or better. That's the big thing, or better. And then the refractive stability over time was quite remarkable. And this is probably what a lot of the refractive surgeons initially do when they look at these procedures is they want to know, is there a statistical significance between these platforms that are available here in the United States? And the answer is no. You can look within the numbers, and remember, never look within the error bars and margin error bars when you're looking at statistical data because it's not statistically significant. But if you look within the numbers, you'll see that one looks a little better at 2020 are better at 6 months, and then the other one looks better at 12 months. And then if you look at the 2040 are better, one is better at this point, and one's better at that point. The issue is here, none of them are statistically significant. Probably more important is to understand that they are all incredibly accurate type procedures. If you had any other medical procedure that approached these numbers of perfect, think about knee replacements, think about, tendon replacements, collarbone repair, back to perfect, and you're batting like 99 to 100%. This is ridiculous. Like nothing in the medical world comes close to this. So again, remember with the cornea, no blood supply, avascular tissue. If you're in quick, you get out quick, you let it heal. The body never knows you were there. You can get remarkably accurate results. And really, the accuracy of surgery these days is wholly due to advancements in femtosecond technology, the idea to be so crazy precise with the incisions. And that's kind of the big thing. And the other thing is this, and I think this drives a lot of people into our practice because we have a dry eye center as well, the corneal nerve damage. If you look at the studies, and corneal nerves are very difficult to stain. As a matter of fact, the first corneal nerves that were stained and seen or published in data was less than 10 years ago. That's how hard they are to stain. But if you look at the regeneration rates through using confocal microscopy or anything like that, you'll see that corneal regeneration rates in SMILE are dramatically faster and better than they were with LASIK, mostly because you didn't actually cut most of the corneal nerves. So let me explain that. When it comes to corneal sensitivity testing, this is the first thing they tested. They wanted to know what happens to the sensitivity of the cornea after you do these refractive surgeries, because that is a hallmark of how much neural stimulation you're getting to produce tears. You can see with LASIK, you have a dramatic reduction in corneal neural sensitivity, and it takes up to a year to get back to similar type levels. And even after a year, LASIK patients never got to the same corneal sensitivity that they were before the surgery. Now, if you look at mean corneal sensitivity of SMILE, you can see it's dramatically less affected. You return to baseline very quickly. Statistically, you return to baseline within a couple months, and then you're there flatlined by 6 months consistently. And LASIK, even after a year, does not approach the corneal sensitivity return that you got when you did SMILE. So for dry eye patients, it's a world of difference. It alleviates a lot of patients' concerns. And the reason for this is, although your corneal nerves enter from the periphery in the mid-stromal area, kind of layer, they all move anteriorly into the stroma and they travel along the top of the stroma and then they poke out into your epithelium. Well, when you're doing LASIK, you're actually cutting the bulk of them that come into the flap. And again, your central cornea area is the part that's most disconnected from your limbus. And you're ending up basically dissecting or cutting all of those, incising all of those corneal nerves, except for one little area that's coming through the flap, and then relying on that to slowly regrow over time. If you look at the far right picture, your incision in the anterior stroma is just a tiny, tiny incision. So you still have all these corneal nerves that are coming over top of that lenticule that we're going to remove, and they are untouched. And that's why the dryness is much, much less of a concern, to a negligible concern when it comes to doing SMILE. And then there's the structural integrity. A lot of people worry about, is there a difference with SMILE for risk of corneal ectasia? And most likely, yes. Now, we haven't had a longitudinal type data to say absolutely either way. But if you look at some of this modeling that was done by Reinstein, you can actually see that if you look at the cornea, it's like a suspension bridge. And we know in a suspension bridge, all of the tension and all the strength of the suspension bridge is in the very top of the surface. The back part of the basically suspension beams have very little structural integrity. And they basically they contribute almost nil to the whole kind of idea of the retaining the integrity of the structure. And so when you look at the different surgeries and where they remove tissue, even with PRK, you can see you're going to drive into that anterior stroma to remove tissue. And obviously with LASIK itself, you're cutting a circle around the eye. you're also going to affect structural integrity more than if you leave the surface of the stroma or the kind of that top one third alone, and you just worry about lenticular removal in the middle. So conceptually, we should be safer from things like ectasia because we're maintaining more structural integrity in the cornea versus mathematical models of ablation of PRK or even LASIK. Hope that kind of makes sense. Engineers will get it. I don't know if any of us others do, but that's the concept. And the other thing is enhancement rates. Enhancement rates are very, very, very low. Now, clearly with Smile, you're not going to go back and do Smile again if someone needs an enhancement. Typically, if someone needs an enhancement, we're going to do just PRK on top. But it's relatively rare and on the order, believe it or not, exactly with LASIK and PRK, the enhancement rates. So there's not a whole lot of difference there. The key benefit of lenticular extraction, honestly, with Smile, is it's way less invasive. You're not going to cut as many nerves. There's no flap. There's no risk of flap trauma, dislocation, anything like that. So that's way better. It's super fast. The lenticular removal allows patients to return to kind of their normal duties right away, very, very quickly. Super comfortable for the patient. I've never had a patient say it's uncomfortable at all. The safety and the efficacy of it has been well borne out in international and domestic studies now. And it's really just getting these people returning to life much quicker. It's not LASIK, so it gives you something new to talk about with your patients. Return to recovery, great visual acuity right away. And again, you're mitigating a lot of these concerns that we had historically with other refractive procedures.